Hi, everyone. Today we have Professor Stephen Nissen with us. Professor Stephen Nissen is the Chief Academic Officer at the Heart and Vascular Institute at Cleveland Clinic and Professor of Medicine at the Lerner College of Medicine. He previously served as President of the American College of Cardiology and has contributed to over 600 journal articles. Thank you so much for joining us today, Professor Nissen.
It is a pleasure to join you.
Thank you. And of course, we're here today to talk about your latest publications from the CLEAR Outcomes trial on bempedoic acid and its effects on cardiovascular outcomes for statin-intolerant patients. But before we go into that, I just want to go through, what is bempedoic acid? How does it work? And why is it coming out as a potential alternative for patients who are intolerant to statins?
So bempedoic acid is an interesting drug. It's an ATP citrate lyase inhibitor. So it works along the same pathway as statins, but upstream. And it has an advantage in that it is a prodrug. When it's taken orally, gets into the peripheral circulation, it's inactive.
Right.
It then gets taken up by the liver, where it's converted to an active form. And that active form then lowers cholesterol. Since it's not active in the peripheral circulation, it can't cause systemic side effects, particularly muscle side effects, in the same way that statins do.
Okay, that's great. And so can you tell us a bit about the research that has been done leading up to your trial? What do we know about bempedoic acid so far, up until your trial, and what led your team into looking into it as a potential drug of interest?
Well, first of all, the drug was approved in the United States by the Food and Drug Administration in the year 2020.
Okay.
It was approved to lower LDL cholesterol.
Sure.
And we knew at that time that the cholesterol lowering from bempedoic acid was moderate, about 20 to 25%. And it was always intended to be used in statin-intolerant patients.
Yeah.
But it did not have any evidence whether it reduced the things that really matter to patients, cardiovascular death, stroke, myocardial infarction, need for revascularization. So we designed the CLEAR Outcome trial to add to the information and, of course, to allow the drug to have a label claim for cardiovascular benefit, which is required in the contemporary era for people to want to use a drug.
And now, so I want to dive into a little bit about the CLEAR Outcomes trial, because it really is a fascinating trial and it has, great implications. Can you just tell our audience, how you designed the trial and what you found, what you measured and what you found from the trial?
Well, first of all, we wanted to study statin-intolerant patients.
Right. If
patients tolerate statins, then statins are the gold standard drugs. They've been studied in hundreds of thousands of patients. So we had investigators enroll only patients who could not tolerate statins. And we made patients sign a statement that said that they understood that statins had been proven to reduce cardiovascular morbidity and mortality, but that they had tried statins, that they could not tolerate them. They had to sign that statement, and so did the investigators, so that we knew we were getting patients that were truly intolerant to statins.
Right.
And that's about 10 to 15% of the population that attempt to take statins.
Okay. And what did you measure and what did you find?
Well, it was a classical outcome trial. The primary endpoint was a 4-component endpoint of myocardial infarction, stroke, the need for coronary revascularization, or cardiovascular death. What we also did, however, was have a hierarchical testing procedure so that we could look at additional endpoints.
Okay.
So if the study was successful at 4-component MACE, major adverse cardiovascular events, we could then look at 3-component MACE, that's just death, stroke, and MI.
Yeah.
And if that were successful, we could then test for efficacy at reducing MI.
Yeah.
And then we could test for reduction in coronary revascularization.
Yeah.
And it turned out that there was a statistically significant effect on all 4 of those endpoints.
Yeah.
For 4-component MACE, it was a hazard ratio of 0.87, a 13% reduction.
Okay.
For 3-component MACE, a 15% reduction. For myocardial infarction, a very large 23% reduction.
Wow.
And for coronary revascularization, a 19% reduction. The next endpoint, stroke, showed a reduction, but it was not statistically significant, so we stopped testing at that point.
Sure. Okay. And so I understand that this was, the trial, that this was the paper that was published in the New England Journal of Medicine. And initially you were looking at primary and secondary prevention, but then you did a subgroup analysis for only primary prevention, which was, later published in JAMA. And why did you feel the need to do the subgroup analysis, and what did you find there?
Well, first of all, we did pre-specify that we would do that analysis. Most contemporary trials are not studying primary prevention patients.
Yeah.
All the PCSK9 inhibitor trials studied only secondary prevention patients.
Right.
The Improve It study studied only, of ezetimibe, studied only secondary prevention patients.
Yeah.
So we took a chance that we thought the drug would work in both populations.
Yeah.
Well, it turned out it actually worked substantially better in the primary prevention patients. That was actually not a complete surprise. Several previous trials had suggested that cholesterol lowering with statins have a greater effect size in people that had never had an event. And that's exactly what we found. We had a hazard ratio of 0.70, a 30% reduction for 4-component MACE.
Right.
6.4, a 36% reduction for 3-component MACE, and a very surprising 0.61 hazard ratio for death from cardiovascular causes, a 39% reduction. There was also a large reduction in myocardial infarction. So what we learned in this pre-specified subgroup is that if you are statin intolerant and at high risk, particularly if you have diabetes, which many of these patients had, there are substantial benefits to taking an alternative to statins, bempedoic acid, if you can't tolerate statins.